Thank you for that introduction, and it is my pleasure to talk about uncontrolled hypertension or resistant hypertension. How common is it, and in particular, what can we do about it? These are my disclosures. And in early 2016, in other words, roughly where we are now, in the context of renal denervation, we have been giving a great deal of thought to resistant or uncontrolled hypertension, because that, in the minds of some people, is a major rationale for renal denervation. I happen to disagree with that, and as the morning unfolds and I have other opportunities here at the podium, I will share where I think renal denervation belongs, which is I see it as a very innovative and exciting opportunity, not necessarily directed here. But we have to focus on three issues. First of all, what is treatment-resistant hypertension? We have to now redefine, in a sense, what resistant hypertension is or uncontrolled, because if you think about it, until recently we said if your pressure is 140 or higher, it's not controlled. Now, as you'll hear in a few minutes when we get to talk about SPRINT, it'll probably be 130 rather than 140. So there'll be a lot more people with so-called uncontrolled hypertension. And what have we learned from renal denervation that has taught us about this condition? Now, these are some of the causes of uncontrolled hypertension. White coat hypertension, and we already had a brief discussion about ambulatory monitoring and how it is supposed to get rid of the white coat effect by getting blood pressures away from the doctor and away from the office. Poor drug selection, or clinical inertia, in other words, an inadequate performance by the treating doctor, a poor performance by the patient, in other words, they don't take their medicines. Secondary hypertension that hasn't been suspected. Taking blood pressure raising drugs. The most obvious example, the non-steroidal anti-inflammatory drugs, the naproxen and particularly the ibuprofen that are so popular. High salt diet, which is really a remarkable issue even in a country like the United States, and probably a big factor in many people's difficult to manage hypertension. And so we're left with true resistance, which I suspect is a pretty rare event. This is a study from Spain, from Dr. de la Sierra and colleagues, including Professor Ruilopi from Madrid. And to give you the data in a nutshell, basically what they found was that of the patients who had office-resistant hypertension, who were about an eighth, about 12.5% of all people with hypertension, they found that 3/8 of them, a little more than a third, actually had normal blood pressures when the pressures were measured outside the office. In other words, they had white coat hypertension. So in one fell swoop, 1/3 of all resistant hypertension disappears if you study it with ABPM. Let's not waste time on this. This is, again, the list of bad guys, the drugs that can raise your blood pressure, and particularly the non-steroidal anti-inflammatory drugs, and many of the cold remedies with Sudafed and other such agents are also blood pressure raising. And an amazing number of people take those sorts of treatments, not just when they have a cold, but just about all the time. This just shows, and I show this with a little bit of tongue-in-cheek, it's from a well-regarded group of investigators published in Hypertension, just the sort of fall you can get in blood pressure if you choose patients on a high-salt diet and switch them to a low-salt diet. A bit of an artificial construct, but it does show that salt can be a major influence of blood pressure, and certainly worth thinking about. These are estimates of how common underlying secondary hypertension is. These are estimates of aldosterone excess, and there are 4 different cities, and they all seem to report similar findings. Somewhere between 15 and a little over 20% of patients have excessive levels of aldosterone. That doesn't necessarily mean that if these patients were worked up, they would be found to have what we would regard as true autonomous primary aldosteronism. Nevertheless, it shows that aldo is a player and should be thought about, and since we have drugs that treat it, such as spironolactone, why not use that information? And here, from one study called ASCOT, we see that patients who on 2 or 3 other drugs were still uncontrolled, just adding spironolactone gave this very robust 20 millimeter of mercury reduction in blood pressure. I'll be honest with you, I don't completely believe this. I believe the data are the data, but when you have this sort of change without a control group, without people being randomized to spiro or to a placebo, you tend to get these big changes. But I'm sure that spiro is very valuable in many such patients. This is a report from Dr. Jung, published in the Journal of Hypertension about 2 years ago, and this has had a big effect on our thinking, because what they did was they looked at their patients who were referred with so-called uncontrolled or resistant hypertension. Just by improving the level of treatment, excluding white coat hypertension, they got rid of most of these patients, reduced it from 375 to 108. Then they found people with secondary hypertension doing all the things I've been talking about, improve the quality of treatment, and they get it down to 76. Now we're down to the real resistant hypertension, and then they did a mean thing. They actually took urine samples from the patients and measured the drugs they were taking, and guess what? 30% of these patients, despite swearing on a stack of Bible that they were compliant, 30% were taking nothing at all, and more than half were taking less than they were supposed to. So in the end, only 36 out of 375 uncontrolled patients had what you might call true resistant hypertension. So less than 10% of an already selected resistant group. So it is a rare finding. So the N. Haynes people say that about 12 or 13% of treated hypertensives in this country are resistant. But if you take, and I'm not going to read this whole slide, but if you take the work I've just referred to, and again the DINA hypertension trial published in Lancet by Michel Azizi, and look at his ability to find people with true resistant hypertension, he had to look at 1,416 patients to find 106 who actually had genuine resistance. So 10% of 12.5% leaves us with roughly 1% of people with hypertension have resistance. A lot of people still in a way, but let's face it, not the epidemic that we've been led to believe exists. How do we treat difficult hypertension? I think all the guidelines agree on this. The 3 core drugs that every patient should get, unless there's some particular reason they can't receive these drugs: blocker of the renin system like an ACE inhibitor or an ARB, plus a calcium blocker, plus a good dose of a thiazide. And then sequentially, we can test, does spironolactone work? If it does, great. If it doesn't, let's try something different. Let's see if a sympathetic drug works, something like clonidine that inhibits central sympathetic activity. If that doesn't work, let's try a vasodilator, or let's get more aggressive with a diuretic. When I see people on 6 or 7 drugs because all of these things have been added helter-skelter, I get a little bit irritated. These are drugs, these last 4, that should be added sequentially, and the beta blockers, of course, would be part of that experimentation as well. When I see a patient on 7 drugs, all I know is that patient is not taking 7 drugs, and if they are, very few of them are actually working. So that's the conclusion. In the hands of experienced clinicians willing to systematically evaluate and treat their patients, treatment-resistant hypertension is a relatively rare condition. Thank you.